Good morning, everybody, and welcome to day 4 of Warm Homes Week. I've been advised to put a little delay before we start talking, just because of the synergies of broadcasting over YouTube and going live on the Zoom call means I think before I've been kind of doing my introductions before anybody's joined us. But hopefully that's not the case now and you are with us. Thank you everyone for coming back on day 4, for those of us who are frequent attenders of these events. A couple of things that so far, this obviously is our first virtual conference, having always had the sociability of a physical conference, but it has meant that we've reached more people. So we've had over 1,000 unique individuals involved as participants in the conference from 600 organizations, almost a full day worth of content, 17 live sessions and 46 contributors. So we've been able to do something bigger and more accessible and more shared than usual, which gives us a challenge for next year when hopefully we'll be able to go back and have our supporters and members and interested stakeholders together in person. We'll need to figure out how we can do that without shutting down that increased access. But thank you very much for coming back. We've had a number of sessions throughout the conference, some of them focused on technology and innovation and optimizing presence in energy markets and ensuring that we do what we need to do to the fabric of buildings. We always try and come back to what the emotional center of what NEA does in the end, and that's to be alert to the vulnerability of people on low incomes or in fuel poverty, to the impact on themselves, on their health, and on their ability to be part of civil society, of living in a cold and damp home. And we know what they are, and I won't go through them in detail, but they're life limiting, it's life threatening, it's life ruining for people of all ages, but especially for those who have a particular susceptibility to the impacts of cold and damp homes. We started the sessions for Warm Homes Week with an analysis of what the impact and what the vulnerabilities brought on by COVID-19 have been and what the response has been. NEA conference, for us anyway, within the organization, it's a transitional point. It's a particular point in the year in mid-September when we start to focus in greater urgency and detail in what winter might be like. We will pray for a mild winter. We will pray that there's no sustained cold weather periods, but we know that even in the most benign kind of winter, the impacts are horrific, and the impacts are excess morbidity, tense pressure on primary and acute NHS services, and excess winter deaths. We're all thinking about excess winter deaths, excess death statistics differently, given what we've been through, but it's nailed on. It's hardwired into the nature of our homes that people will be particularly susceptible to the impact of cold and damp homes in cold weather, primarily through respiratory conditions, but through strokes and through heart attacks and through lots of different areas. And I do not want to catastrophize what we think might happen over the winter, because we don't know, but we have a legitimate fear that this could be a lethal cocktail of conditions. And even those people who have been and may need to continue shielding from COVID will still be exposed to the impact of living in cold and damp homes. So it's a transitional period into winter when we don't know what's going to happen, but we fear that the usual and predictable impact of cold homes will be worsened to an impossible degree. I'm delighted nonetheless with that sobering introduction. I'm delighted that we have a focus not only on health, housing, and fuel poverty, but from the 3 nations around which NEA operates, from England, from Wales, and from Northern Ireland. I was just saying to the participants, I'm kicking myself that we didn't include colleagues from our sister organisation, Energy Action Scotland, because it would be good to have the 4 nation ones. But it is important that we take sight of what is happening, and also importantly, what is not happening sufficiently in England, Wales and Northern Ireland, because as we say often, we seem to have an allergic reaction to learning what's happening across different jurisdictions in the UK, and that needs to come to an end. And there are challenges and opportunities and good practice happening across the UK, which we need to learn from. So I'm going to introduce the participants now. So I'm delighted that we have David Orr, former CEO of the National Housing Federation, the chair of the Good Home Inquiry, which is sponsored by the Centre for Ageing Better. It's an inquiry focused on England. I think it's an evidential review, but David and the Centre means it will not be an exercise in bibliography. There will be activist and purpose behind it. Delighted that we've got Samina Azam and Emily Bebbington from Wales. Samina, head of policy at Public Health Wales, and Emily, a medical practitioner, but also an academic, I think, in Bangor, to think about prevention, winter resilience and what we can do. And then delighted my colleague, Pat Austin, NEA's director in Northern Ireland, to think about how, at least in one area, we've been able to think through the implementation of NICE guidelines, not leave them on the shelves, but try to see what they're like when put into practice. In Northern Ireland, I think we have a particularly strong track record as a fuel poverty movement of working with the Public Health Agency and the Housing Executive. So some good lessons there. We're going to give people a bit more time to speak than we have in previous sessions. So I think David about 15 and Emily and Samina about 15. Pat only gets 10, unfortunately. It's just the way it is. And then we've got plenty of time for questions. As always, you can see us. We can't see you, but you can share on chat. If you want to ask a question, please ask it through the Q&A button at the bottom of your Zoom screen, because that enables colleagues in NEA to curate, moderate, and make sure that we're seeing the right questions. We're already up to about 168. I think that's going to grow any further. When Samina and Emily talk, can you please get your questions in early? Because Samina, unsurprisingly, as a head of policy in Public Health Wales, has other things she needs to be doing. And so if you could get those questions in early, that would be great. If there's a really good one that comes up after the event, then we'll pass it on to Samina later on. So without further ado, I'm going to hand over to David to talk us through the Good Home Inquiries. David, great to have you on the panel.
Well, thank you very much, Adam. And thank you to NEA for inviting me to come along and speak at this event today. I'm really pleased to have the opportunity to do so. I'm going to tell you a little bit about the Centre for Ageing Better and the Good Home Inquiry and the thinking behind it, and how I believe it is so critical to the work that you are doing. So the Centre for Ageing Better, for those who don't know, is an organisation established 5 years ago on the back of a substantial endowment from the Community Lottery Fund. And it has a very simple ambition, which is that all people in later life should be able to live good and fulfilling lives. And to ensure that people have the best opportunity to live a really fulfilling life as they get older, we've been exploring a number of different key issues, things that contribute to that. Inevitably, health is one of those. Connected communities and the ability that people have to engage with each other and still to be part of their community is really important. Fulfilling employment is the third of our four main areas, and then housing. And for housing, we've identified two kind of big goals over the next few years. The first of those is about building new homes. And it is that we believe that all new homes should be built to accessible standards. And there is a program of work underway to try to ensure that that happens. And actually, the recent government housing announcements, so a lot of which were rehashing old stuff, some of which are unhelpful, but it does have a very helpful commitment to exploring how we improve the accessibility of our new homes. So there, you know, some good things already happening out there. The priority goal that we have in respect of existing homes, we know that there are something like 4.4 million homes in England that are assessed according to the government standard as being non-decent. It's a rather clumsy way of describing it. And, the decent home standard is very much a minimum standard. There are plenty of things not included in it, including actually accessibility. But the fundamental problem is that we've got some of the oldest housing stock in Europe, and some of that housing stock is in very poor quality. Numerically, the biggest number of non-decent homes are owner-occupied. And proportionately, those owner-occupied homes that are non-decent are lived in by older people. And the older you get, the more likely you are to live in a home that is classed as failing to meet the government's decency standard. The biggest proportion of homes that fail to meet these standards is in the private rented sector, and even in the social rented sector, which has the benefit, of course, of public investment and, generally speaking, high quality landlords. There are still pockets where the quality of the homes is not good enough, partly because they're very old and need very substantial new investment. We've been exploring how to deal with an ambition to reduce by 1 million the number of people living in non-decent homes, and thinking it's not a very good definition. I think we need a bigger ambition than this. We need to try to find a way of changing the conversation about homes and housing. And if you think about the way that the housing debate happens in this country, well, the first thing is that it happens sporadically. It gets a bit of focus. I have long experience of being invited to speak on Newsnight or the Today programme or breakfast television, and 10 minutes before some other story breaks, and it's always the housing one that gets pushed off the bottom, because housing is not regarded as being one of the key public social policy priorities. But when we do get involved in a conversation about housing, it very quickly becomes a conversation about building new homes. Absolutely critical. I mean, I bow to no one in my enthusiasm for seeing new homes being built. We need a minimum of 90,000 new social rent homes every year, figures from the National Housing Federation Commission from Glenn Bramley at Heriot-Watt University. And we need 300,000 homes a year. I share the government's ambition for doing that, and we have to be much better at meeting those targets. But almost no one talks about our existing homes. And the real housing crisis is in the homes that people already live in. As Adam kind of suggested, we have some quite polite language, don't we? A kind of winter death spike. It's not very polite language, but what that actually means is our homes are killing some of us. We live in homes that, because they're cold and damp and can't properly be heated, they are killing us. This is unacceptable and ought to be regarded as a national scandal. And this is something that, frustratingly, we know how to do. We know how to deal with this. We know how this can be made better. Actually, in a lot of homes, it requires a very small amount of investment. In some homes, it does require quite substantial sums of money. But all of this we already know, and yet we just kind of park that as though it is inevitable and something that we can do nothing about. As part of the inquiry, we've commissioned some desktop research with the King's Fund about the impact of poor quality homes on our health. We will be publishing this research next week. I don't think anyone in this audience will be surprised at the findings, because in a line, the findings are that poor quality homes are very bad for us. There are all kinds of things, kinds of medical conditions, a phrase I absolutely hate, comorbidities, which are caused by or exacerbated by living in poor quality, damp, cold homes. Now, if we are to address this, we have to give it some proper focus. And the COVID pandemic has, without question, refocused attention on this. because all of us have had to rebuild a different kind of relationship with our homes. And as night follows day, what we have found is that people who are already vulnerable in some respect, living in poor quality homes, are more vulnerable to COVID and are more likely, if they contract COVID, to have much poorer outcomes. So the work that we were doing was already critical. The COVID pandemic has made it absolutely essential that we get some real focus on this. We're going to be doing this in a number of ways. I mean no disrespect to anyone when I say that I have been involved in all kinds of inquiries in my life. I've even commissioned some of them, which have followed a standard pattern. You get 10 or 15 sector experts, you have 8 meetings with them over the course of an 18-month period, you do a call for evidence, you get bombarded with people's great ideas, you write a really thoughtful, intelligent report, heavy on policy recommendations, that everyone says, what a great report. They read the recommendations, say, yeah, that's good. And then it goes onto the shelf and no one does anything with it. I'm not interested in doing that. What I'm interested in doing is running an inquiry which is very clearly focused on change, and not on change after we've done all the work, but change as we go. If we can persuade change to happen next week, next month, then I will be absolutely delighted. We are obviously very keen to ensure that any recommendations that we make are properly backed by the evidence. We're not issuing a general call for evidence, though, because we know that there is a stack of evidence already there. So we've commissioned research which is about looking at all the evidence that's already there, identifying policy and practice initiatives that have been sponsored by government and others over the years, seeing what's worked, seeing what hasn't worked. And we are conducting some very detailed, very in-depth research into lived experience. We have a group of people who have been very engaged in very detailed and thoughtful conversations from which a great deal of high quality and useful information is coming. So we will ensure that anything we do is based on high quality evidence, but we are also very keen to be agile in the way that we do this. We will be doing a section of the report which is specifically about energy efficiency. I mean, this is, I have found this, I've spoken on conference platforms all over the world about this, how frustrated I am that we have so many homes that are poorly insulated, where people get ill and die. And you can do something about it, which helps them. That is a great outcome. But if you do something that helps them, you're also spending money in the economy. And there is a huge demand, which if we can properly focus it, would be a real economic driver. Post-COVID, that is really important. If we are successful in doing so, then the 25% or so of CO2 emissions that come from our residential homes could be reduced. In theory, it could be reduced to zero, a fundamental contribution to the challenge of climate change. So we will have a section of this inquiry which is very, very focused on energy efficient retrofit and the impact that that will have on people, all people, but particularly older people. We will be looking at questions of digital connectivity. One of the ironies of the pandemic is that there are a small but really important number of people who were very isolated in their homes. And then the pandemic came along and all of us became more aware of our local neighborhoods. The big charities who still do fantastic work, it wasn't the big charities who were absolutely on the forefront. It was local community groups. It was neighborhood street groups. I don't know if any of you are on a street WhatsApp group. They were almost non-existent 6 months ago, and there's thousands of them across the country now. So we've re-engaged with our neighbors in a way that hadn't happened previously. And we also know that particularly where there are large-scale social landlords, people who'd not been engaged with anyone, Well, there was a program of phoning absolutely everyone over 70 or everyone who was known to be in some way vulnerable. And that reconnected with people, and some of those practices are going to be embedded. But we have absolutely discovered that if we are maintaining physical distance, one of the best ways of maintaining social connection is digitally. We have 200 people engaged in this conversation right now, and most of us are at home. We can do far more of this. I think that we now come to a point where if we're building new homes, it should be as unthinkable that they are not digitally connected as it would be for them not to be electrically connected. So there are a number of very important issues that we will be looking at through the lifetime of the inquiry. We will be asking people to contribute their expertise in different components of it. We will be looking at the financial mechanisms that we could put in place, real practical mechanisms that are designed not to produce a beautiful suite of policy recommendations, but are designed to stimulate change that helps to improve people's lives. Energy efficiency will be absolutely central to that. And I am sure that any of you or any organizations that we ask for support will be more than happy to help us out. Thank you very much.
Good start. Thank you, David, very much for that passion. A couple of things there immediately. I think I might have been on the same or similar inquiries over recent years. I recognise some of that. NEA will do whatever we can to support this inquiry. We hope to perform some sort of connective tissue function between different organisations, and we'll try and make it easy for them to support. But I'll concur with two things in particular. One is that the sum of human knowledge is sufficient in terms of what the problems and solutions may be. The sum of political will and motivation is seriously lacking, and we need to drive that forward. On the digital exclusion, we had a fantastic session yesterday, exactly on that, on digital exclusion, which is on YouTube for posterity, and we'll make sure we tweet out the link to that, because that's certainly our learning as well. Great start. Thank you so much. If I can now turn to Samina and Emily, and Samina from Public Health Wales. I hope Public Health Wales is going to continue. Some of us are a little anxious about what's happening, the aftermath, the rearrangement of Public Health England, and we'll see how that kind of works through, but I'm not expecting you to address that particular question. Great to have you here. Winter resilience, winter preparedness, winter awareness is an annual recurring theme for NEA. Delighted that you're here to talk through the reasons why and possibly the how it looks in Wales. So over to you, and we can start the slightly anxious sharing of screens. Perfect.
Hello, and thank you, Adam, for the kind introduction, and to David for that first inspiring speech. I'm Dr. Emily Bebbington, and I'll start the presentation and pass over to Samina partway through. So the talk today is based on our report, Improving Winter Health and Wellbeing and Reducing Winter Pressures in Wales, a Preventative Approach. And if you scan this QR code with the camera on your smartphone, it should take you to the website, which has the report, the technical report and infographic at the bottom of the page. And we'll show the QR code again at the end of the presentation if you've not managed to catch it now. So why did we produce this report? Well, winter brings adverse health outcomes, and the tip of the iceberg is excess winter deaths. In 2017 and 18, there were 3,400 excess winter deaths in Wales. And this isn't purely due to cold weather, but that is a big contributor. And negative health outcomes are seen at relatively moderate temperatures of 8 degrees. And some populations are disproportionately affected. Now, this leads to increased stress on health and care systems known as winter pressures. And this is something that I've experienced firsthand every year since qualifying as a doctor. And every year the shifts in the emergency department over winter seem to get more emotionally and physically grueling. It manifests as long ambulance waiting times, patients queuing on corridors, long wait times to see doctors, and delays going from ED to a ward, and then delayed discharges. The list just goes on. Currently, these winter pressures are reacted to with short-term funding that primarily focuses on trying to improve flow within the health and care systems, but this approach isn't sustainable. So there needs to be a move to tackling the problems at their sources. So I became involved in this project because I think that prevention is the only meaningful way we will reduce pressures over winter. So our aim was to take a preventative approach, applying public health principles to improve winter health and well-being and reduce winter pressures in Wales. And this is the first report that we know of to take this approach. We also wanted to make this accessible to everyone, and that's really our key take-home message. Everyone has a role in reducing winter pressures. Now, this was a very ambitious project that hadn't been done before, and we needed to cover a lot of ground, so we took a mixed methods approach. First, we completed a thorough literature review of 3 key areas. Firstly, health conditions associated with winter months and cold temperatures. Second, common risk factors associated with winter morbidity and mortality. And third, evidence for interventions that could protect against or prevent winter morbidity or mortality. We then collated statistics from a range of sources, including national statistics, hospital statistics, and surveillance data, amongst others. And we also completed 19 semi-structured interviews with individuals from a range of backgrounds, with experience from practice to policy, including NHS, care, third sector, and government. So the results, well, we found that 35% of excess winter deaths in England and Wales are due to respiratory diseases, such as flu, COPD, and pneumonia. 23% are due to cardiovascular disease, such as heart attacks and strokes, and 22% due to dementia. We also found that a 1-degree reduction in temperature increases death from respiratory diseases by 3% and cardiovascular disease by 2% in the over 65s. Now, this may not sound like much of an increase, but these are very common diseases, and it's only for a 1-degree drop in temperature, so the absolute numbers each year could be very large. What those statistics tell us is just the diagnosis of death. It doesn't tell you why or who is most at risk. Now, the elderly are by far the most at risk, with 75% of excess winter deaths being in the over 75s, which seems to be due to a combination of factors such as having more comorbidities, being less able to keep warm, having a less adaptive physiology, and also being less active, along with being maybe less able to make choices about wearing which clothes to wear and heating and things. And what probably comes as no surprise to this audience is that fuel poverty contributes 10% of excess winter deaths, and cold homes account for 30% of excess winter deaths, which I have to say, I found quite a shocking statistic as a clinician. We also looked at the evidence for interventions that have positive health outcomes. Those with good quality evidence of effect include flu vaccines, washing hands, falls preventions, vitamin D supplements, and road maintenance. There was limited evidence for positive health effects for winter healthy behaviour campaigns, advice to the public on energy efficiency, giving financial help, and also winter weather alerts. Now, that isn't to say that these interventions don't have a positive effect, just that we didn't find that there was much evidence, and so we really need to be doing many more studies. I'll pass over to Samina now for the rest of the talk.
Thank you, Emily. So the next 3 slides are showing the impact of poor winter health on emergency hospital admissions, which Emily highlighted as the tip of the iceberg. So this slide I think is quite interesting because it shows winter admissions between the years of 2015 and 2017. The yellow dotted line is the upper limit of temperature, and the blue dotted line is daily temperatures on the lower side. So what you really need to focus on is the continuous blue line, and that shows the daily admissions to hospital as an emergency. And what you'll see is in the blue shaded line, which is the winter period, we have regular increases in hospital admissions. You can see those peaks, which happen regularly every winter. The other interesting thing to highlight with this graph is that there seems to be a year-on-year increase in hospital admissions. So that's an upward trend. Next slide. So the next slide refers back to something that Emily mentioned earlier, the causes of hospital admission in winter. Emily mentioned respiratory diseases, so the likes of bronchitis, pneumonia, influenza. Now, if you look at this graph, it shows hospital admissions for a range of diseases. But if you look at the turquoise line, that's the one which is looking at respiratory diseases. And again, you can see that every winter there's a sharp peak, a sharp increase in admissions due to respiratory diseases. Next slide. So this slide is close to my heart, and it's looking at admissions according to deprivation levels. So what we've done here is divided the population into fifths of deprivation. And at the bottom, the turquoise line, it looks at the least deprived population at admissions levels for those. And right at the top, you can see admission levels for those who are in the most deprived populations. And you can see worryingly a gradient between different deprivation levels. So this graph clearly shows that deprivation is closely related to hospital admissions. Next graph. Next slide. Thank you. So data is really important and it's vital in helping us understand what the problems are, but it doesn't tell the whole story. We spoke to a range of stakeholders across sectors at different levels, and they all said some really interesting and thought-provoking things. We've highlighted three here, and some of the themes that come through are prevention, vital if we're going to get on top of preventing poor winter health, preventing pressures on hospitals. Poverty comes up an awful lot, and fuel poverty. And the other themes that I'll come back to is that we shouldn't be looking at annual winter planning. We shouldn't be looking at short-term spending rounds. We should be thinking more long-term. One of the quotes that didn't make it onto this slide is comparing winter admissions to planning for a garden. So if you have a garden with strong trees and embedded flowers, and which is mature, they've all got strong roots, and they're very strong, and they're resilient to whatever the weather. However, if you've got something which is more akin to the Chelsea Flower Show, which you put into place each year, it's not resilient to those adverse weather events and all the things that may hit us throughout the year. Next slide. So some of the key themes that came through from stakeholder interviews and which they thought were important in terms of changing in future were the importance of integration and collaboration between sectors. And many of them thought that this was going in the right direction, but there was certainly room for improvement. Community services and community interventions were highlighted as being incredibly important in terms of community resilience, preventing knock-on effects to hospitals. So this is both in terms of preventing admissions, but also in speeding up hospital discharges. The next 2 points are very much interlinked, and this is about long-term planning and long-term funding rather than having short-term cycles, as I've mentioned earlier. So that makes us a lot more resilient to all extreme weather events, such as flooding. The thing that really heartened me was that nearly all stakeholders mentioned the wider determinants of health, poverty being key. And one of the participants mentioned the word bravery, that it's actually, you have to be quite brave to start investing in prevention. But that's really what needs to happen. Next slide. We wanted our report to be useful, so we focused on outputs which could be used by our readers in terms of taking action. First of all, we analysed the evidence and summarised it in a way which enabled quick understanding of what was out there. We developed a framework for action which highlighted key actions in order to prevent adverse health events over winter, and we also highlighted who could take action. We knew that many of our readers would be involved in service delivery or commissioning services, and we wanted core messages that could be shared with citizens as part of their work. We also developed a health and housing collaboration checklist because we recognise the importance of the health and housing sector working together in order to tackle many of the core issues that affect our population. Next slide. So this is an example of the evidence summary. And as you would expect, we've picked cold homes and fuel poverty, but there were many themes that we looked at. So for each of these themes, we looked at the epidemiology, we summarised the epidemiology. So here we've highlighted that 10% of excess winter deaths are due to fuel poverty. We also did an at-a-glance summary of the evidence. So as Emily talked about earlier, we highlighted that there's very good evidence in terms of improved ventilation, improving health in young children, that there's less direct evidence in terms of energy efficiency measures in improving health. We also highlighted what stakeholders thought could work. So stakeholders were almost unanimous in saying that a warm home is key, that we should be tackling fuel poverty, and that energy efficiency is important. We also highlighted some of the key examples of interventions in place in Wales. Next slide. Our framework for action took on 4 themes and who should take action. So it was a nice colourful table. The theme of strengthening preventative action included supporting fuel poverty, taking action on fuel poverty, taking action on cold homes, and supporting vulnerable populations. Next slide. Our messages for citizens were things that were consistent, things that could be shared with people in our communities, and some of the things that might sound obvious to us but may not be well known. So not many people may know that a home colder than 18 degrees causes harm to health. And the other thing that sort of rings true now is the importance of preventing the spread of infections. So these are messages that I think are still very, very relevant for today. Next slide. Coming back to a point that Adam made earlier on about looking forward to this winter, before we entered the presentation, I just wanted to highlight this report by the Academy of Medical Sciences. So this was published in July, and this was looking at potential scenarios going forward to this winter. And as Adam had highlighted, it does look like there will be challenges going forward. There certainly will be. We have COVID, of course, to worry about, but as a result of COVID, we've had disrupted health and social care services. There's a backlog of care that needs to be managed. And of course, we do worry about influenza going forward. The thing I found heartening about this report is that amongst the many recommendations it makes, it does highlight things such as ventilation, such as maintaining a warm home, such as tackling winter, such as supporting the most vulnerable and providing winter fuel payments. And it also highlights the importance of tackling fuel poverty. And in this slide, I've provided a link to the report. Final slide. So I saw earlier on that somebody wanted to know if there was another way of accessing the report. So we've provided links here to the main report, but underlying the main report, we also have a technical report with all the more detailed statistics and findings from our stakeholder interviews, which may be of interest. We would be very happy to be contacted. So I've included my email address if anybody wants to contact me directly. Thank you.
Thank you very much indeed. There's so much in that, and maybe not questions now, but just I think one thing that's inevitably going to come up in the questions is I think we would all, especially all those community organisations that are trying to deliver services to fuel poor clients, absolutely get the shallow, deep root kind of analogy. But I guess we've got a particular challenge because I think there'll be questions about, well, given COVID, what else do we need to do? And actually a question for everybody attending, not just for the panelists, if you've got either experience of things that are happening in your community which we might be able to learn from, or things that you would expect to do, let's share them in the chat. But that tension between the long-term plan over successive years and what do we need to do now is, I think, is one I'm sure will come up. I was really struck by I was expecting seasonality, but you're showing a step curve going up on emissions year by year in cold times and in relatively kind of warmer kind of winters. So that's a worry. Anyway, thank you very much to you two. And I'm going to turn to my colleague Pat. We've had nice guidelines for some time, and they're actually pretty good. And they're pretty. If they were all put in place, then we'd have a much better connection between the world of health professionals and the world of fuel poverty activists. But for every, I use this so much, people are bored of me saying this. For every oasis, there's a whole process of desertification around of it where we need to make progress. Anyway, we think in Belfast in particular, there's a particular kind of way of trying to make those nice guidelines work. So Pat, over to you.
Okay, thank you, Adam. Good morning, conference. I'm delighted to give you a little whistle-stop tour of some of the work we're doing in Northern Ireland. I just want to set a little bit of context initially for those of you who maybe don't know as much about us. We're a population of 1.8 million, and that's 800,000 households, and we're quite rural. About 35% of our population resides in rural communities. We share the same social security protections from Westminster, albeit with some nuances with the welfare reform, but our energy has devolved to Northern Ireland. We have our own regulator for electricity and gas, but unique to Northern Ireland, we have 68% of households reliant on home heating oil, which is non-regulated and remains stubbornly high in Northern Ireland. We also have a relatively new gas network. We've only got gas in Northern Ireland since 1996 in the Greater Belfast area, and we're still building a gas network. So we're pretty much out of step in relation to some of the things that's happening across in GB, and we work with our partners and especially across the policy team to try to get better traction in Northern Ireland in a range of these areas. We do have a fuel poverty strategy and fuel poverty programs, probably spending in the region of about £20 million a year. We still use the 10% definition, which indicates the 22% of households in Northern Ireland experiencing fuel poverty, with a higher incidence in rural communities and a higher incidence in the private rented sector, which again would be reflected throughout the United Kingdom. The strategy is well out of date, and we're waiting on a new strategy, and we've been promised that's imminent, so hopefully that is the case. But today I've been asked to focus on how nice guidelines, excess winter deaths, have helped us in Northern Ireland with our work. And I should say that previous to the introduction, as Adam has highlighted, we have been fortunate to have some very strong advocates within public health. Before 2009, we had an Investing for Health strategy, which was our public health strategy, which funded project work probably back from 2000. And since the inception of the Public Health Agency in 2009, we have continued to secure funding yearly, which has sustained and maintained our Northern Exposure Programme and has enabled us to tackle fuel poverty across Belfast, pretty much using a community-based development approach. And while the key anchor in that programme has been referrals to direct interventions in terms of new heating systems, moving particularly oil to gas, insulation, benefit uptake, every couple of years we have different iterations in terms of that programme. Some of those have been ad hoc and some of those have mainstreamed and shaped what Northern Exposure looks like today. We've looked at local area-based approaches in high incidences of fuel poor areas, rapped 100 doors, looked behind the doorstep to see what's been going on, and as a consequence of that have secured funding from the housing authorities to insulate kitchens. We have carried health evaluations out with the University of Ulster, trialled some small innovative products, and also most recently we have with one of the major Belfast hospitals, we've established a respiratory programme with the respiratory unit. So the nursing staff will work with individuals, refer to NEA, and we'll provide an in-depth home visit to assess their energy needs and indeed connect them into the referral partners that we have. So fair enough to say that some of those nice guidelines that we see, we were touching on. But so the programme has been pretty good. We have looked at about and provided interventions in 1,000 households, probably secured in and around the regions, is probably conservative to say, £4 million of investment to improve energy efficiency. And alongside that, throughout the years, we've been working directly with statutory staff to look at health and identify fuel poor issues, and again establish referral mechanisms to ourselves. So Northern Exposure has proved a very good test bed, and it has been in place since 2009, which has been a good thing. So you could, as I say, you could say that we were hitting on some of those 12 recommendations that are cited in the NICE guidelines. Certainly the aims to improve health, to identify fuel poor households, to identify debt and try to prevent that, and improve energy efficiency has been there. It was already happening. But the introduction of NICE guidelines to Northern Ireland back in 2016, timelines are slightly different to yourselves in GB, but the guidelines have provided an excellent framework for us to hang our hat on, and show what the best practice is, and helped us indeed to reinforce the key message. A key message for NEA is that the cold kills, and in the 21st century it is a modern day scandal, as David has already said. So back in 17-18, there was a spike in the deaths to 1,500. And as the World Health Organization tells us, a third of those deaths are directly attributable to living in coal damp homes. They're preventable deaths. It's not cancer. We need to tackle this issue, So we put a briefing together on the excess winter deaths to all the councils in Northern Ireland, and we were invited to speak to the Belfast City Council. And from this, we were brought into a partnership with the Belfast City Council, the Public Health Agency, the Belfast Health and Social Care Board, under a broader Belfast agenda and a community planning process that was being established and embedded in the Belfast area, and indeed throughout all councils in Northern Ireland to varying degrees. So this key strategic kind of group of people enabled us to pool resources. We scoped out an exercise to see where the highest incidence of the Belfast deaths were, and located two key areas not surprisingly in the poorest areas of Belfast. And we selected those two for a pilot. We assessed the community assets from all those agencies, where the money was going. We scoped out who needed to be trained, and that was provided to the voluntary community and statutory organisations. We targeted funeral directors, we targeted taxi depots, we targeted pharmacies, anywhere where there was a local person who had local access or pathway to homes, and provided them with advice and information on the programme. We established a crisis fund, and some money was pulled from Belfast City Council and some of the partners in order to provide direct interventions of the nature of maybe top-ups to electricity, top-ups to gas, radiators, emergency type responses, which has been absolutely fantastic. For anybody that needs more information on that, there was a workshop held yesterday, but that programme currently is hitting most of the NICE guidelines, developing the strategy. NEA is the single point of contact, and it is growing, and as it becomes more successful, it becomes busier, and we need more resource to help individuals. Project got off the ground just before Christmas, and the type of people we were helping, you wouldn't believe it, because we were getting good quality referrals from community midwives. So for example, just before Christmas, we had a referral from a midwife who had discharged a person had been in the home of a young mum, had 2 other children and a small baby, and literally would have been put back into hospital again, had an emergency response, had we not been able to make that emergency response and put electricity on the electricity meter. And these are the things that are happening, as I say, throughout the COVID, even more so throughout the COVID. And more importantly, we're now finding people who have never negotiated the benefit system before, new to unemployment, new to this whole world, and we are already, through these statutory organisations, embedded in some of the COVID response. So referral networks have been strengthened. The crisis fund is providing real, tangible help for individuals. The cases are not just older people, they're all tenures, and the working fuel poor as well. And we're working with other key agencies to connect up this process. So just to say, project is working on the ground. It needs broadened and it needs mainstreamed across Northern Ireland. It is only in Belfast. It's providing rich research to help us influence our policy work, and it helps us in our day and daily work of knowing and understanding what it is we do and why we do it. Thank you.
Thank you, Pat. Questions are flooding in, and for the panel, if you spot one that you really want to answer or you think that gets to it, then do jump out. But there two strike me straight away that are probably worth considering. So David's comment about digital exclusion, Pat's comment about the need to engage with local communities who may be digitally excluded, and what we keep hearing, which is there's a lack of presentation at GP surgeries or hospitals because of anxiety about COVID, or at least there was during the heightened kind of issues with admissions to COVID. What do we do? You know, what do we do if we, what are the activities that we're not currently doing or need to do more of? And I suppose a question which is germane in Wales, but everywhere else as well. Each of the constituent countries of the UK is in the middle of constructing its fuel poverty strategy. And in Wales, I think we have the Wales Winter Protection Plan that came out, and I'm not sure there was much focus on fuel poverty in that. Each of those governments, we keep telling them, have more levers that they can pull than they actually do. Even if it's not a devolved kind of responsibility itself, nonetheless, if you're the national government in Wales, then you have levers that you can pull. How do we enable all the levers that are accessible that can be pulled to ensure that we get local activity, local engagement with communities who may not get picked up by primary or acute care, or who may not be presenting themselves or engaging through digital communities? It's the biggest question I could ask, and it's unfair really to do, but thoughts kind of on that. And maybe come back to Serena, because I know you're going to need to go, about how the plan in Wales is hardwired into local authority planning around social services and government plans around fuel poverty strategies.
That's a huge question. I sort of did note the very first question on the Q&A, and it was about the Winter Protection Plan and how we move forward. And I'd also read the Winter Protection Plan and noted the same thing about how it focuses very much on acute protection from COVID. And I can understand why that's happened, because it's such a mammoth event for society, for everybody. And I can understand why that's the priority. However, thinking back to 6 months ago, Emily and I were having conversations and presenting our findings to Welsh Government on this report. And I think we'd had conversations, during the winter period as well. And one of the things that we both noted was that the Welsh Government plan, which had been produced in parallel to ours, so we hadn't actually had sight of each other's, was very much aligned in terms of prevention. So, from what I could see in Wales, there was a move towards a preventative approach to winter planning, which I think is fantastic. And the other thing that I'm aware of from a housing perspective is that there's strong recognition of the links between housing and health at government, but also at different levels, at local authority levels within the health sector as well. And I know that we've got some mechanisms in place in Wales which can help change happen. So we've got regional partnership boards and also public service boards, which are the engines for sort of delivering local change, but also investing in local areas. So I must admit, I'm answering the question a bit of a roundabout way, but I think the mechanisms are there, but it may not be that this year it's quite clear how we make that change happen because of COVID.
It was a roundabout question. There was a gyratory system of a question, so that's fine to answer it in those terms. If anybody else wants to jump in, please do. David, I think you've unmuted.
I have unmuted, yes. I mean, of course, your question is huge and kind of central. So 2 or 3 observations. For reasons that I completely understand, but remain frustrated by, the response of the health service is always to dealing with the symptom rather than providing the cure. So the winter planning is all about how we deal with the number of people we expect to arrive at the door of the hospital, rather than ensuring that they don't get there in the first place. And in a way, that's not a surprise, because the health service responds to what turns up on its doorstep. it needs a much greater degree of strategic partnership where people are talking coherently about the relationship between, I mean, housing in particular and health, because housing is such a key determinant or influencer of what your health is likely to be. And if you look at the STPs and the ICSs and what other three-letter acronyms you want, where the health service is looking strategically at how to deal with all of this. One or two, no, more than one or two, a few of them mention housing. One of them properly thinks and considers about the relationship and the role that housing has, but most of them don't at all. And I think we've all got some kind of obligation to be much better at saying, yeah, social prescribing and a warm home, that is an absolutely critical response at that end of the pyramid, but there is an equally important strategic response at the other end of the pyramid that we're not really getting to. And I think, as you yourself alluded to, Adam, in response to my presentation, the thing that most drives this is political will. I mean, do we actually want to do something about this? And I've believed for a long time that there is an answer out there that is not ruinously expensive for the country. And I think it was Pat who said, you know, this is not cancer, this is people dying of cold in their homes. If it was cancer and 20,000 additional people were dying of cancer, there would be a national outcry about it and a real focus on what are we going to do to reduce the number of, we need that kind of focus. We need that kind of sense that this is a strategic national problem that, I mean, this is the ideal moment to start fixing it.
I think that's right. I mean, COVID supercharges everything, but it supercharges this as well. I wonder if you could, I mean, so I absolutely don't defer for a minute from the political will. The challenge that the many in the fuel poverty movement have had, there's no silver bullet, but if there was a silver bullet, it would probably look something like a really strong referral pathways or warmth through prescription from all levels of health professionals, pharmacists and discharge nurses and midwives and acute care practitioners, through to those insufficient resources that enable us to take action on people's homes. But what more, I have a question to Emily and Sumina, because we all understand, and actually we're all a little standoffish because we understand the pressures that the NHS are under. The level of priorities are enormous. There will never be enough resources going into the health service to be able to respond to all the needs that present themselves in the way that new technology and an aging population requires it to happen. Are we missing a trick? And if so, what is the trick of trying to tap into stressed health professionals with commissioning groups and other sorts of priorities to make that referral pathway, that warmth through prescription, more possible?
I'll kick this off if that's okay, and I'll share an anecdote with you from last winter. I had a lady in her 80s who normally lives next door to her son, and she had a solid fuel heater in her house, and that was the only heating in the whole house. And her son had gone away for a week, and by day 2, she couldn't cope anymore, and she ended up calling an ambulance and coming into hospital because her heart had gone into a funny rhythm, which is one of the side effects that we recognise from happening from cold weather and winter. And with very little treatment at all, I managed to get her heart back into a normal rhythm, and she was suitable for discharge. Except it sort of became evident that really the only reason she was there was because she couldn't cope with dealing with the solid fuel heater herself. So fortunately, because I've been doing this winter pressures project with Sumina, I knew about the NEST scheme. I certainly didn't know about it, and other schemes as well. And I wouldn't have known about it from my medical training otherwise. And I got printed off some resources for her, not just a website, also a telephone number, something that I thought she'd be able to access. And we arranged a hospital transport, and it was during the daytime, so it should have been a safe discharge, and we got her home. Well, 24 hours later, she was back in hospital because she still couldn't cope. And this is my major point. I think by the time people arrive in hospital, or maybe even at their GP, it's too late. There needs to be processes in place so that this all happens automatically. Yes, I'm there, and I'm myself and my colleagues, I'm sure, be very welcome to pass on resources, but probably by the point people end up in hospital, particularly in an A&E department, they're too overwhelmed, they've lost their autonomy to be able to think about that. It's got to a crisis point. Maybe at discharge, that could be considered, but again, that's difficult. And that's why we talk about prevention, getting people optimized year round, continuously planning. You know, as doctors, we might not be that brilliant at referring people to services, but we certainly are good at recognizing those who are vulnerable, seeing how to optimize them, seeing how to optimize their health, and then knowing about home and optimizing that can be better, and then thinking about ways to reduce their risk. And so that would be my major point. Don't know, I'm sure Samina will have something to add to that.
Thank you, Emily. As you were speaking, I was just sort of thinking through what the levers are in terms of how we could actually affect change. And I think one of the things that at a strategic, political level that can sometimes cut through is evidence presented in an accessible way, with the figures there, but underpinned by something really robust. In Public Health Wales, we've started on this journey. So, housing and health is one of our key interests. Well, it is for me and one of my colleagues. And I think it was 2 years ago, we developed a report which was about the benefits of investing in housing. And this is from a perspective of if you invest in housing, including things like, fuel poverty, tackling fuel poverty, you improve health and well-being. So actually, you get a return on investment. So it's a good thing to do all round, not just in terms of, health and well-being, but also it makes good financial sense. So there are good co-benefits. So we know that that's sort of been taken on board, and we talked to colleagues in Welsh Government about it. And I think, it's helping to sort of inform thinking, which is what we want. But I think there's also something here about the ongoing advocacy, because these pieces of work, they come out, and unless I keep shouting about them, which is why I'm here actually, because this work was done 10 months ago, but actually I think it's still very relevant. Unless we keep advocating and sharing findings and having these discussions, it doesn't work. And it takes advocacy from those of us who are within the health and care system, but also from other partner agencies who see the impacts, of us not of the lack of pathways being in place. So I think it's a really difficult problem. I think in Wales, it feels like we're heading in the right direction. Emily, when we often talk about this, we often sort of think about the Wellbeing of Future Generations Act, which is about thinking about things in a holistic way. It's not just about health, it's not just about poverty, it's not just about the environment, it's all of those together. So I think we've got the framework in Wales, but it's how we actually make it work. And I think that's the journey that we haven't quite got there on. So it feels promising, but we do have further work to do.
I'm really interested in the impact that the Future Generations Act has on all levels of public service delivery in Wales, and what the learning of that is for across to the UK. May come and pick your brains on that later on. Pat and David. So David, one of the challenges that the inquiries have got, which I'm sure that the Centre and yourself and the inquiry members will be up to, is how to transition, communicate, drive evidence to cut through in ways that make sense. And Pat, I know we've got experience in Northern Ireland about the way in which you can work and reinforce and get long-term commitment from public health kind of agencies to recognise the value to their own objectives in doing it. But I have to say, it does seem to be a challenge in both the housing and the fuel poverty movement, that we're often up to our gills in evidence and insight and information, and we refresh it and we refresh it, and we think we've got win-win-win, and we can think, why on earth? Just what is the problem of people not being able to see it? But does that speak to, and maybe the inquiry is one way we're going to do that, the need just to go again and think through the way in which we present our information that makes sense to kind of public sector organisations to deliver services, but also to politicians to put it up their rank of priorities. David.
I certainly hope so. One of the ambitions that I have for the inquiry is that we will be imaginative in how we communicate and engage. The combination of research that we are paying for at the moment, that's being undertaken, is about quantitative research, obviously, but also qualitative research. And the stories are the thing that grab people's attention. Now, it's how you manage to use those stories to get public cut through and political cut through, underpinned then by the clear quantitative evidence. And I mean, the report that we're launching next week with the King's Fund, I see that one of the questioners has asked about whether cost-benefit analyses have been done. Yes, they have, and there's plenty of evidence that investing in housing will certainly have the effect of reducing demand on the health service. But the problem that we have is that the housing investment is expensive and it's upfront and it comes from one bit of the public purse, and the health service benefit or revenue in the longer term and in any event come from a different part of the public purse and probably don't translate into real actual financial savings. What they translate into is a reduction in demand, which is then filled by other people who are looking to access the health service. So we have to be a bit more thoughtful in how we manage to kind of insert into this whole debate the idea. This is something that Stephen Dorrell, who some colleagues may know, who among other things was chair of the NHS Confederation for a number of years. He used to go to health service conferences and say, what do you think primary health care is? And people would talk about GPs and various other things. And he'd say, you're all wrong. Primary health care is having a good, warm, dry home. We have to find some way of getting that thinking embedded in the policy decision-making and to persuade people that it's not just an issue that affects other people. It affects all of us because of the increased demand on the health service, and it affects all of us because who knows when our homes are going to become cold and damp or we're not going to be able to afford it. So there are some big comms and media challenges that we have to get round.
Indeed. Pat, our experience in trying to get this to lodge, and I did see a comment from colleagues at the Centre for Sustainable Energy who are also doing great work in trying to connect, get people working within the health sector to make that referral pathway not only possible, but actually deliver benefits. And there's lots that we should learn, but there's lots of oases and unfortunately just too much desert in local areas. Pat, a little bit about how we're able to make sure that the benefits of it can resonate with the public health agency.
It needs to be, we need to do it continuously. Sometimes we think individuals have the message and that's not good enough. You know, we still need to be showcasing, providing the evidence of where it works and where it doesn't work. And it amazes me that in 15 years of the job and people that I've been working with, they still are shocked to hear about excess winter deaths. And I still think that a lot of people don't actually believe it. I think we still have hearts and minds to win in the debate. And there's a lot about behaviour and there's a lot about the role of GPs. We know older people who simply don't put their heating on until October. It's a behaviour that they have been, you know, they've had all their life. They're not understanding that there's a physiological response to being cold and the impact that has on falls and all the plethora of things that go with that. So we need our GPs to be sending those messages out, public health agents to be sending those messages out, and of course we will have the problem with affordability. But if our leaders are telling us that it's important, back into David's points, into the points that everybody's making today, a cold home can kill you. And that sounds very dramatic and very emotive, but it is the truth. And I think, again, we have to keep saying it and we have to keep saying it and it has to be embedded. But to walk away and think, surely they know that by now, is wrong. I've made that mistake with the Public Health Agency as well, where I have to keep continuously going back to remind them of the importance of these schemes. Now, the Belfast agenda at the moment and the new council structures have been very fortuitous for us in enabling us to get this Warm and Well project off the ground. But you know, we can't sit on our laurels. Not saying we do, but we mustn't do that.
So I mean, there's a couple of other things that have come up in the Q&A that are kind of interesting. One, I think for David, your current role, but also your previous life, is a lot of the progress in energy efficiency has been made in the social sector, but we need to do more. The big hard nut challenge is not just owner occupiers, but also the private renter sector. Where do you see the real challenge for the fuel poverty movement, but also for the centre in trying to reach those different most difficult bits of tenure, and how we can get the most out of social landlords and break into private landlords?
So for social landlords, I mean, we know that this statistically, the quality of homes in the social rented sector is better than in owner occupation and private renting, because there is constant investment, but it's still not good enough. And there are some particularly older homes where the challenge of keeping them warm and dry is a real challenge and very expensive. And there have been a number of mechanisms tried to create a kind of revolving funding mechanism. And I think that there is a real prize there, which feels like it's just about within our grasp, but we've never quite got to it. So there's further work to be done there, but I think there is the possibility. I mean, there are programs, I don't know if anyone here has heard of Energy Sprong, but look it up. It's, you know, there are a number of different programs that have the potential to make quite a big difference. I think for owner occupiers, the fundamental problems are lack of trust in contractors, lack of knowledge of where to go to ask, and lack of information about where if cost-effective funding might be. And these are all resolvable problems with a bit of kind of strategic oversight, a bit of investment, putting an infrastructure in place that makes it much easier for people to kind of navigate a path, get the advice, get the information that they need, and be confident that the contractor that they've contracted with will do a good job, that they trust them. And again, everyone here knows all of this, but these are the kinds of detailed things that I think we can make real progress with. The private rented sector is a harder nut to crack. There are large-scale landlords in the private rented sector who are very good, and you know, the people who are building to rent now tend to be institutions that have a long-term commitment and, you know, have decided that this is a business model that they want to employ. But we have in excess of 800,000 small business landlords, and finding a route to having a collective conversation with that group is a challenge. And the representatives of the private rented sector will be a really important part of the discussion that we have.
Indeed, and a group that it's been difficult to break through and persuade of the value to them in their own kind of property, kind of maximization of its own value. We started this week with a focus on the way in which COVID has revealed what people who is vulnerable and what they're vulnerable to in the energy market. Now, clearly, we know that older people are much more susceptible to the conditions and the health implications of living in a cold home. But also, of course, we're seeing that the rise in fuel poverty amongst young people and young people with children expressed not just in physical ill health, but in mental ill health and loneliness and the inability to go out to do simple things like about home and do simple things to live a social life, live a sociable life. I was wondering, Samina, I'm so glad you've hung around, whether Samina and Emily in particular have got any insight about that aspect of living in a cold home, because my huge anxiety is not just for people who are shielding, but those folk who might be the prospect of staying in their homes, in their cold homes over winter, with the added stress about why you're doing that and what you're trying to avoid is of epidemic proportion already and likely to get worse. Is that filtering through into the work of Public Health Wales in particular?
It is. So with regards to cold homes, I think, we know that cold homes are bad for children in terms of mental well-being and also in terms of school attainment. So, it has long-term knock-on impacts for children, for their life chances. So it's really important that, even without COVID, that we address it. We recently did a health impact assessment looking at the impact of the lockdown policy. And one of the things that we found was that this touches back on something you said earlier about how actually the home is really important. The quality of the home that we live in impacts on our experiences of lockdown. So if you're living in a cold home with, surroundings that aren't conducive to good health, your health will suffer. So I think that COVID has really highlighted that as an issue. The other thing I think that's come out of this is the importance of mental well-being. There's lots of data coming out now about mental health, particularly of children and young people, and how much it's being affected, and how much we're seeing loneliness emerging as a really important issue with increasing social isolation due to all of these measures in place. And yes, it has very much filtered through in terms of our work in Public Health Wales. So we're currently doing work, of course, on the acute protection from COVID, in terms of keeping people safe. However, we recognise that there's broader impacts of COVID, so the broader harms, which are going to have long-term impacts on health and well-being. We're sort of identifying key issues in terms of what we focus on to try and address those. And of course, we know we can't address them on our own, but we can be part of the response and help the direction, hopefully. So some of the things that we've sort of identified impacts on particular population groups, such as children and young people that need particular focus. Mental well-being has come up as a major issue. And the other thing that is a real concern is employment, and that then impacts on housing security, which is also incredibly important for us going forward. So I think absolutely, the home is central, particularly when we are forced to stay there due to lockdown, due to any sort of restrictive measures that come into place.
And added to that, sorry, David, go ahead.
I was just wondering if I could come in there again, because that is, every single word of that is absolutely spot on. I completely agree with everything that Samina just said. I think part of the problem is that our collective response is then to think, right, what is the minimum that we need to do to be able to make a bit of a difference? That's kind of tactically rational, but it doesn't really take us anywhere. So we need to have something that is a little more visionary. That, one of the things that the Good Home Inquiry will be exploring, not necessarily a new set of technical standards, but trying to define what a good home is. And a good home isn't just its technical specifications, it's that there's light, that there's space, that there's flexibility, there's adaptability, that it faces onto and communicates with the rest of the world, that it's digitally connected, all the things that we've been talking about, that it's easy to heat in the winter and, equally important, easy to cool in the summer, because we are getting a rapid growth in heat deaths in the summer. So we need to specify, we need to have a kind of a picture of what we're aiming to, even if we won't always get there. If you don't have this picture of what a good home looks like, it's very difficult to say where the journey is going to take you. That's the kind of visionary bit. There is one thing, I have been obsessed by this for a long time, but there is one thing which I just think is still an absolute disgrace in our welfare system, which is the bedroom tax, which writes into our welfare system that children won't have enough room to be able to study, that you can't have the spare room to allow someone to come and stay. It writes in overcrowding in an environment where we're spending more and more time in our homes, and where the dangers of that to young people as well as to older people, to the future that children have, is being compromised. And honestly, if I could get nothing other done this year than the bedroom tax being abolished, I would think that was a good year.
you'd have done a good job in that case. So the twin aims of both being able, for tactical reasons, but also in order to leverage some money out, need to focus on the emotional and the real stories of morbidity and mortality, but also a good home as a precondition for a good life, around which we can orient ourselves and try to get some positive visionary traction. We tend to make a lot of the comparison between a lot of the alignment between fuel poverty and the pathway to net zero. And what net zero has or tries to do, the climate change movement, is obviously coming from moments of extreme global jeopardy to try and think about how it works, how it works and how it's beneficial and how we're going to live new lives. If anybody has spotted a question that addresses their particular interests in the Q&A, then please do shout, because I think my own moderation of the questions is obviously not going to be comprehensive. One thing that, David, you mentioned, and I think we all experience, is that reaching out and engaging people who are classified as hard to reach or vulnerable, or not the ones that are able to or feel confident or able to present themselves for support, are trusted intermediaries. And on the Q&A, William Baker from Citizens Advice asked the question, well, could social landlords help us as trusted intermediaries with other kind of forms of tenure? But of course, the big trusted intermediary, I'm almost coming back, and this is rhetorical rather than expecting a particular answer, is at that moment of crisis, that moment of jeopardy, people in the medical profession are trusted to tell it straight and trusted to give the pathways towards a solution. There's something there about how we can extend the advocates of warm homes amongst other groups in order to provide more points of contact with trusted intermediaries. But I was wondering whether there's any of the Q&As that have been coming through that anybody wants to jump on. And if not, then I shall jump again, and to really thank all the panelists for a fantastic, informative and passionate session. What we really wanted more than anything else was to bring these sessions to an end throughout the life of Warm Homes Week, focused on the way in which human beings, those awkward, soft, fleshy, vulnerable people, experience life in a cold and damp home, and to think about how David's point that we can think about how a good home is a precondition for a good, healthy life, not just for those who are particularly vulnerable to virulent diseases or other conditions, but for everybody throughout the course of their lives. That is a perennial issue. I think we always finish these with, well, we need more stories, we need more challenging stories, we need more positive stories, because I think that we're all right that emotional core of what we do can dissipate as we try to construct the most tightly argued evidential presentation to politicians and policymakers about why this is in their own best interests. We need to always appeal to those other forms of motivation, which are something they can be proud in, something they can achieve, something which has a sense of mission and determination for it. Thank you so much to the panelists, to David, Emily, Sumida, thank you for staying, and to Pat. I'm just going to take the chair's prerogative, because we're coming to the end of Warm Homes Week, just to thank everybody who's been involved in these sessions. And we haven't quite finished yet, so please come along, and unfortunately you have to put up with me again as we work through some of the lessons we need to draw from one of the worst examples of failure in retrofit from Fishwick in Preston. And there's also an opportunity to the session run by the NUS on the hidden poverty in the student population. But I want to thank everybody, over 1,000 people who've been part of these sessions. This is a bit of a challenge, so thank you to my colleagues in the NEA comms team and the policy and research team and everybody else who's been responsible for putting these things together and making them a bit of a success. If you've been on these calls before, you'll have heard me say that next year is the 40th anniversary of NEA. We started out as Neighbourhood Energy Action, a project of the National Council for Voluntary Organisations in the Northeast 40 years ago. Next year is our 40th anniversary. We hope, beyond hope, that we will be having a physical event where we're able to engage our supporters and stakeholders and colleagues in something that's as much a birthday party with purpose as it is about a physical virtual conference. All the presentations and all the videos from the sessions throughout Warm Homes Week are available on our website. I think also there's a separate URL for it, which is warmhomeweeks.uk, because you'll find those not on our current website, but on the website that will take over from that in a matter of weeks, I hope. Couple of things for me to end it. I think that going into the next winter with the prospects of COVID, which we've talked about now, are both the greatest single challenge to understand the vulnerability of people to cold and damp homes, but also, without being morbid, it is the greatest opportunity. While the consciousness of the nation is focused on what physical vulnerability to virulent conditions, especially respiratory conditions, is, the inadequacy of the steps that we have to deal with the immediate crisis through our health system and elsewhere, but the continual failure to engage with a cold and damp home as an underlying condition for medical illness, ill health, physical and mental. I am not pretending for a minute that we will be able to come out of this pandemic crisis having settled on the causes, the consequences and the solutions and commit to them. But like David, if we haven't pushed this agenda further and we haven't used every opportunity to underline the centrality of a warm and decent and healthy home to a warm and decent, healthy life, not only in health terms, but in civil society and a productive economy, then we would have missed an opportunity. No one thinks we'll get it done in one fell swoop. No one thinks we'll get it done completely, but we'll need to do it. I'm drawing from this session a couple of really important lessons. Firstly, that it is so essential that we hardwire that connection between medical practitioners of so many different sorts and those individuals, organizations, and sometimes companies that are able to help people insulate and make homes warmer and healthier, and that is incredibly challenging. You have the insufficiency of resources on the one hand, and the complexity and competing priorities of the health system on the other hand, but we do have examples of where it works. We know the motivations exist across that supply chain to make it more efficient, and we need to go back and make that happen. And then thank you to David, because we constantly need to re-inject in the fuel poverty movement ambition and vision and determination. And we do it continually, and we're just going to have to keep on doing it continually, because celebrating a 40th birthday next year is great, but it means we're celebrating 40 years of continuing to have to be here and continuing to have to make a difference. And we take that seriously, and we do not want to celebrate a 40th birthday subsequent to that. So thank you so much to everybody who's participated in the sessions, both attending and panelists. It's been fantastic. It's been a bit anxiety creating for some of the NEA team, but I think hopefully people feel it's gone well. I hope to see you all next year in some conference centre somewhere in the UK for a celebratory event. I hope that people still take advantage of the sessions and the materials available on the website. What I really hope, though, is that anybody who's got a question they put that didn't get answered, or anybody who has a question or a comment they wanted to put but didn't put, or anybody who's got a connection that they want to make, please make it. Please contact us directly. What NEA always tries to be is a body that's able to work with all the different aspects, all the different sectors and interest groups that are involved in the fuel poverty movement to make us bigger than the sum of our parts, more effective than the sum of our parts, and are able to see some way towards making some traction towards having everybody in the UK able to afford to live in a warm, healthy, good place to live. So thank you very much for your time. A couple more things this afternoon, but it's been great to do this. You're sick of the sight of my face on these Zoom calls, but hopefully we'll be doing this again sometime very soon. Thank you ever so much, the panelists. Thank you to everybody else. Bye-bye.